British. Calcaneal fractures account for approximately 1.2% of all fractures, sir. Calcaneal avulsion fractures are more frequently observed in elderly women, particularly those with osteoporosis or diabetes mellitus, because the displaced fragment is subjected to strong traction forces from the gastrocnemius soleus complex. Early repair and fixation are recommended to minimize soft tissue compromise, prevent posterior skin necrosis, and to restore the plantar flexion strength. Here calcaneal avulsion fractures were defined as an extra-articular fracture line extending from the calcaneal tuberosity located posterior to the subtalar joint, involving the osseous insertion of the Achilles.
Data is taken from where?
9 hospitals.
Retrospective study. How do you collect the data?
From hospital data will take, sir.
From where? From hospital medical records.
Medical records.
So you take out all the case sheets. All the case sheets.
Yes, sir.
All the case sheets. Then you analyze.
Yes, sir.
So what is the disadvantage of retrospective study? What's the disadvantage?
Subject bias will be there, sir.
Why subject bias?
Selection of cases can be manipulated there.
There is no manipulation.
Selection of cases can be manipulated there.
There is no manipulation. Retrospective means bias. Bias may be a little bias, but what is the main disadvantage of a retrospective study? What is the significance given to retrospective study? You know, grading? How important it is? Is it significant or not very significant?
Not very, sir.
So, why it's not?
Usually prospective cohort is at the
No, I'm asking retrospective. You have to listen, answer to the question. Okay? What is the disadvantage of retrospective study? Anybody? Who else is there? Amir? What is the main disadvantage of retrospective study? We discussed many times. What's the disadvantage? Because data is collected already, you don't know whether the data is there, what you want. Some of the data may be missing. It's all retrospective. They did not know that you're going to do a study.
yes.
So data is collected and you can't change the data. That's why it's not, some of the important factors might not have mentioned. You wanted to assess some function which may not be recorded there. And many other, that's what retrospective means. The data may not be sufficient. Okay. And it's not individualized. There may be variation. There is no protocol at the time of treatment.
Yes.
So, everybody will not follow the same treatment protocol. Prospective study, you design study and you follow the
Protocols.
whatever design study. So here there is no, everybody has their own way of treating. Okay.
Yes.
Go on.
So surgical treatment was cannulated cancellous fixation alone, cannulated cancellous screw fixation with augmentation using washer, suture anchor, tension band wiring, and Steinman pin, or augmentation alone was done, sir. After surgery, all patients were made non-weight bearing with immobilization by a cast in equinus position for 2 to 6 weeks. Non-surgical treatment, 6 to 8 weeks of cast immobilization in mild equinus, followed by weekly radiographs and soft tissue evaluation. Assessment after treatment, the American Orthopedic Foot and Ankle Society score was used at 3, 6 and 12 months after surgery. Radiographs, lateral view and Harris axial view were evaluated preoperatively, immediately postoperatively and at 3 to 6 and 12 months, sir.
Do you know how to take Harris? You know?
Patient is supine, sir. The beam is directed craniocaudally at 40 degrees
Where is the plate? Where is the beam?
Plate is over the plantar aspect of the foot, sir.
Hmm.
So the beam is directed at 40 degrees to the plate, sir.
Okay.
This is a Bevis classification which is used for extra-articular fracture, sir. Uh, Type 1 is a sleeve fracture, sir, where small shell of cortical bone avulses from the tuberosity. Type 2 is a beak fracture, where an oblique fracture line runs posteriorly from the most superior portion of the posterior facet. And type 3 is an infrabursal fracture from the middle of the tuberosity. So these are the number of cases that were there. Results, sir. Postoperative complications. Among the 50 surgically treated patients, complications occurred in 15 patients in the form of infection, skin necrosis, and loss of reduction. Of the 9 cases with loss of reduction, 7 required reoperation and 2 were managed conservatively. Steinman pin fixation resulted in complications in both the cases where it was used. The CCS fixation analysis. CCS was the main fixation method for 40 cases. 20 cases were treated with CCS alone. 20 cases were received CCS with augmentation, sir. So out of the 20 cases, 7 cases went into reoperation, sir, with CCS alone. CCS with augmentation, out of 20 cases, only 2 cases went for reoperation, sir.
So what do you think? What's the main complication of surgical repair of tendo Achilles? Avulsion or non-avulsion injuries?
Avulsion.
No, you don't listen to the question.
Sorry.
I'm asking you, let me finish the question, then you understand. I'm asking you, what is the main complication of surgical treatment of tendo Achilles rupture or avulsion? Main complication.
Posterior skin necrosis.
Skin problem.
Skin problems.
See, main complication is skin necrosis, wound healing. That's the main problem. That's why there are various other ways. Minimal access, especially in the exam, let them finish and take a gap of 10 seconds. Okay, go on.
19% were diabetics, sir. Yes. Discussion. This study shows that the calcaneal avulsion fractures occurs mainly in the elderly women and have a high complication rate after the surgery. Complications were more common in patients with greater initial displacement, smoking history, and CCS fixation without augmentation, sir. CCS was the most commonly used fixation method. It provides stable fixation through a small incision. However, CCS alone had a higher failure compared to CCS with augmentation, sir. So augmentation improves fixation strength, especially in osteoporotic bone, and should be considered whenever possible. Steinman pin fixation was unsuccessful and is not recommended, sir. Limitations and criticism, sir. This is a retrospective design. Sample size is, sir, they have given the name that surgical versus non-surgical, but they have used surgical only.
Not anything.
They said that if it is undisplaced and the skin condition is good, go for conservative. You can go for conservative, sir. If it is displaced, it is better to fix it.
Right. Okay. And do you know how augmentation? How do you augment?
Using washers or TBW or suture anchors, yes, mentioned.
Okay.
Yes, yes, yes.
Yeah. Nowadays, that's what we discussed.
Yes, sir.
But you didn't tell me